Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to another deep dive. Today, we are speaking directly to you, the surgeons, the emergency doctors.
The registrars.
Yeah, exactly. The registrars and the clinical leads tuning in who are out there managing the acute take. Now, before we begin, please note that this content is for reference only. Always follow your local guidelines and protocols in clinical practice.
Right, because clinical judgment and, well, the specific realities of your hospital's resources always have to take precedence. We are just here to synthesize the broader evidence base so you can make those split-second decisions with a bit more confidence.
Exactly. And today we're tackling a presentation you probably see on a near-daily basis, Small Bowel Obstruction, or SBO.
Oh, absolutely. It's everywhere on the surgical wards.
It is. It's responsible for a massive chunk of all emergency laparotomies in the UK. And in high-risk groups, it carries a really sobering 10 to 15% mortality rate.
Yeah, which is staggering when you actually stop to think about it.
It really is.
Yeah.
And the challenge you face on the floor is that there's no single unified national UK guideline for managing SBO. Instead, your practice is shaped by this really dense, overlapping web of guidance. I mean, we have a whole stack of major sources on the table today.
A literal mountain of paper.
Right. We're looking at the WSES Bologna guidelines, the RCS Emergency General Surgery Pathway, the ASGBI's Agreed Pathway, the NASBO audit, and that highly critical NCE-PI, or Report the Delay in Transit one, plus some cross-cutting NICE and SIG guidance.
And honestly, sifting through all of that while you're managing a surgical ward, an overflowing ED, and an active theater list...
It's impossible.
It is an impossible ask for any clinician. The literature is dense, and sometimes the recommendations from different bodies seem to pull in slightly different directions.
Which is exactly why we're here. Our mission for this deep dive is to cut through that noise. We're going to synthesize these overlapping documents to extract the ultimate evidence-based clinical pathway.
Stripping away the theoretical fluff.
Yes, exactly. Focusing purely on the critical timings and the specific interventions that actually move the needle for patient outcomes. Look at the clinical reality. Okay, let's unpack this. And I think we need to start with the first 24 hours of admission.
Those initial hours dictate the entire trajectory of the patient's hospital stay. Yet according to NCEPO's Delay in Transit report, the front door is frequently where the system just outright fails.
Yeah.
Their data highlights that delays at every single stage, from the initial surgical review to getting the patient into the scanner and ultimately to accessing the operating theater, are incredibly common, and they correlate directly with increased morbidity.
To combat that, the RCS and other bodies have established a firm consensus on system-level urgency. The overarching rule is that SBO patients must be admitted directly under a surgical team, not medical.
Never medical.
Right. And they require consultant review, ideally within 14 hours of admission. Now, that sounds like a solid metric on paper, but let's be realistic here.
Yeah, the logistics.
If a patient comes in at 2 in the morning on a Sunday, securing a consultant review before the afternoon ward round is a massive logistical hurdle. Does the data show this 14-hour window actually changes survival rates?
Well, the 14-hour metric is really about preventing the insidious deterioration that happens when junior staff are left to manage borderline cases overnight.
Without a definitive management plan.
Exactly, because while you're waiting for that senior review, the resuscitation clock is already ticking. The immediate steps are universally agreed upon. You need strict ABC assessment, aggressive intravenous fluid resuscitation, adequate analgesia, and prompt NG decompression.
And we cannot understate the physiological chaos happening in the patient's abdomen during this time. The bowel is third spacing massive amounts of fluid.
Liters of it.
Yeah, you have liters of fluid pooling in the dilated bowel lumen and the intestinal wall. Add to that the constant vomiting, and the intravascular volume depletion is profound.
What's fascinating here is a specific finding from the NCEPO data regarding that front door physiology. They found that roughly 25% of SBO patients arrive at the hospital already suffering from an AKI.
Wow.
Yeah. 1 in 4 patients are stepping through the doors with their kidneys already taking a massive hit.
That is a huge trap right at the start of the admission. You're essentially dealing with profound dehydration and wild electrolyte disturbances before you even confirm the diagnosis.
And many of these AKI episodes are deemed completely avoidable by NCEPO. The trap is that clinicians sometimes under-resuscitate because they're so distracted by the surgical picture.
The classic surgical tunnel vision.
Precisely. If we implement highly protocolized early fluid resuscitation and diligently track baseline labs, specifically FBC, UNEA, CRP, and lactate, we can protect the kidneys. You have to stabilize the physiology and correct the hypokalemia or hyponatremia before you can even think about safely inducing anesthesia.
Okay, so the patient is aggressively resuscitated, crystalloids are running, the NG tube is actively decompressing the stomach, and we have our baseline blood sent off. The next immediate hurdle is imaging.
The big shift.
Yeah. Looking across the WSES, RCS, and NCEP outsources, there is a definitive shift in the imaging paradigm that we need to talk about. The era of the plain abdominal film is officially over.
Thank goodness. Yet we still see them ordered constantly in the emergency department.
It's a historical reflex, isn't it?
It is a reflex that every major guideline now explicitly advises against for primary diagnosis. A plain film might show you some dilated loops or air fluid levels, but it doesn't give you the actionable data you need to make a surgical decision.
Right. The consensus is absolute now. A CT of the abdomen and pelvis with IV contrast is the definitive initial imaging modality for any adult with suspected SBO.
Because the diagnostic power of a modern multi-detector CT is unparalleled. We are talking about an accuracy rate of over 95%.
It's incredible.
It doesn't just confirm the presence of an obstruction. It acts as a highly detailed anatomical roadmap. It pinpoints the exact transition point. It identifies the underlying cause, whether you're dealing with an adhesive band, an incarcerated hernia, an internal hernia, or a primary malignancy.
And more importantly, it highlights the surgical red flags.
Yeah.
When you're reviewing that scan with the radiologist, you are hunting for signs of a closed-loop mesenteric edema, free intra-abdominal fluid, or the absolute dread of reduced mural enhancement.
Yeah, if the bowel wall isn't enhancing, you are looking at ischemic dead gut.
Which changes everything.
It does. NCEPO stresses that the timing of this scan is critical. You cannot formulate a safe clinical plan without it. Delays to the CT scanner strongly correlate with delays in definitive treatment. Every hour that passes with a closed loop sitting undiagnosed is an hour closer to a bowel resection and a stoma.
Let's assume the ideal scenario. We get the CT quickly, and it confirms an uncomplicated adhesive SBO. There's no free fluid, no pneumoperitoneum, and the bowel wall is enhancing beautifully. Here's where it gets really interesting, because the next step for this patient isn't necessarily a trip to the operating theater.
Right. If the scan is reassuring, the clinical consensus points heavily toward a trial of non-operative management, or NO. This is the absolute first-line treatment for adhesive SBO, but it hinges entirely on patient selection.
The criteria are super strict. You can only proceed with NO if there is no clinical peritonitis on examination, no CT-confirmed ischemia, and no strangulated hernia.
Absolutely.
If the patient meets those safety criteria, the core elements of the conservative bundle kick in. Strict nil by mouth status, continuous NG decompression to relieve the proximal pressure, meticulous IV fluid management to replace those ongoing third space losses we talked about, and serial clinical reviews.
You're tracking the lactate levels and performing repeated abdominal exams every few hours. You are watching them incredibly closely. And the guidelines, particularly the ASGBI and WSES, are heavily pushing a specific intervention during this observation period, the early use of water-soluble contrast like gastrografin.
Yeah, the protocol is usually to administer the contrast via the NG tube within the first 24 to 48 hours if the obstruction isn't spontaneously resolving. You clamp the tube, let the contrast sit, and follow up with a simple abdominal X-ray at 24 hours.
And if you don't see contrast in the colon by the 24-hour mark, the conservative trial has likely failed.
But the water-soluble contrast isn't just a diagnostic dye to see if the plumbing is open, is it?
No, and that is the most elegant part of the protocol. Water-soluble contrast has a proven therapeutic hyperosmolar effect. When it sits in the bowel lumen, the high osmolarity literally draws fluid out of the edematous bowel wall and into the lumen itself.
It's brilliant.
It really is. This fluid shift decreases the swelling in the bowel wall, increases the pressure gradient across the obstruction, and stimulates peristalsis. In many cases, it is the exact catalyst needed to resolve the obstruction entirely.
And the data backing this up is incredibly robust. The multinational SNAP SBO study looked at exactly this pathway. They proved that high compliance with this specific bundle, early CT, effective NG decompression, and the early administration of water-soluble contrast directly leads to significantly shorter lengths of stay.
And better overall composite outcomes for patients. It actively prevents unnecessary laparotomies.
It's a structured approach that works beautifully. However, you're always operating against a ticking clock, and managing that psychological tension is a huge part of the job on the surgical ward.
Definitely.
We need to define exactly when to abandon ship. The guidelines list absolute contraindications to NOM, which act as immediate triggers for urgent surgical intervention. These include the development of generalized peritonitis, signs of septic shock, or any new CT evidence of ischemia, perforation, or a closed-loop obstruction.
If any of those clinical or radiological red flags appear, the trial of conservative management is instantly over.
Done. The RCS pathway provides a very strict timeline for these critical patients. The 6-hour rule. If ischemia or strangulation is suspected, the patient requires emergency surgery, and the national standard dictates they must be in theater within 6 hours of that suspicion.
That's the black and white standard.
But let's talk about the gray area. What about the patients who remain clinically stable, but the obstruction just isn't shifting? How long do we wait?
Well, the WSES guidelines support observing a stable patient for up to 72 hours. But that requires the patient's pain to remain easily controlled, their inflammatory markers to remain flat, and their NG output to be steadily decreasing.
We've all been there on day 2 or 3 of a conservative trial. The patient looks okay, but the NG is still putting out a liter of bilious fluid a day, and the anxiety just starts creeping in. Do we give it one more day?
If we connect this to the bigger picture, balancing the 72-hour window is arguably the most difficult clinical judgment on the acute take. We know from the literature that non-operative management boasts a 60 to 80% success rate for ASBO. However, retrospective series consistently warn us against the trap of endless observation.
Right.
Pushing conservative management beyond 3 to 5 days does not statistically reduce the eventual need for surgery.
It just means you're eventually taking a much sicker, more physiologically depleted, and highly malnourished patient to theater. The bowel's more friable, the anastomosis is riskier, and the postoperative recovery is infinitely harder.
Delaying past that 72-hour mark simply drives up your morbidity and complication rates. But the NCEPO report highlights a darker reality regarding these delays.
The logistical nightmare.
Yes. Often the delay to theater isn't a failure of clinical decision-making. You might make the perfect call at the 48-hour mark that the conservative trial has failed and the patient needs a laparotomy. But if there is no emergency theater space and no anesthetic team available, the patient just sits on the ward.
NCEPO points out that delays in acute bowel obstruction surgery are frequently driven entirely by hospital logistics. The system bottlenecks. This is why every hospital needs strict local escalation policies, ensuring these deteriorating SBO patients can actually access the prioritized theater time they desperately need.
Absolutely essential.
Now, assuming we navigate the logistics and get the patient to the anesthetic room, we have to talk about the surgical approach. Open laparotomy versus laparoscopy.
Historically, a massive midline incision was the only acceptable approach for a bowel obstruction. And to be clear, the guidelines state that an open laparotomy absolutely remains the gold standard for complicated cases.
Right, there's no debating that.
If the CT shows massive abdominal distension, a suspected closed loop, or if the patient has a history of multiple laparotomies predicting a hostile abdomen full of dense, matted adhesions, an open approach is by far the safest option.
However, the WSES and the ALSGBI, the UK's Laparoscopic Society, do support a laparoscopic approach, but only for highly selected cases.
Very tight criteria.
Exactly. You are looking at patients with perhaps a single adhesive band, limited prior abdominal surgery, and no gross bowel distension obscuring the visual field. Crucially, it must be performed by a surgeon with significant emergency laparoscopic experience.
The risk-reward calculus here is intense. When laparoscopy is utilized correctly in those highly selected patients, the benefits are undeniable. Significantly lower wound complications, a drastic reduction in future incisional hernias, and a much faster return to normal bowel function. But if you push the indication, if you try to insert ports into a massively distended abdomen, you risk the ultimate nightmare, an accidental enterotomy.
Oh, that's the worst-case scenario.
Creating an unintended hole in dilated edematous bowel during an obstruction case is a catastrophic complication that dramatically increases mortality.
So, assuming everything goes well, once you successfully resolve an ASBO, whether open or laparoscopically, the immediate problem is fixed, but the long-term risk remains. The surgical dogma is True adhesions breed adhesions.
They absolutely do.
Every single episode of ASBO increases the patient's statistical risk of presenting with another one in the future. To mitigate this, the guidelines strongly advocate for proactive adhesion reduction strategies.
This involves using barrier agents, such as hyaluronate CMC or icodextrin during the index operation. Applying these barriers is particularly vital for younger patients who face a significantly longer lifetime horizon for recurrent obstructive episodes.
We spend so much time discussing the surgical mechanics, but the recovery on the ward is where we see a massive, largely ignored crisis in SBO management: clinical malnutrition.
It is shockingly overlooked.
Both the NASBO audit and the NCEPA report explicitly highlight that over half of SBO patients are at severe risk of malnutrition during their admission. Yet, our routine nutritional screening on the wards is just poor.
Consider the physiological toll. These patients are made nil by mouth immediately. They have an NG tube actively draining whatever nutrients and electrolytes are left in their stomach. Their bowel is inflamed, and they might remain in this catabolic state for 5 to 7 days before they can tolerate a diet.
The guidelines lay out specific interventions to combat this starvation. First, a routine must score must be calculated on admission for every single patient, without exception.
Basic but essential.
Second, and this is critical, these patients must be housed on dedicated surgical wards. NCBPAD data clearly shows that when SBO patients are placed as outliers on medical wards due to bed pressures, they experience significantly longer periods of starvation.
Medical nursing teams simply aren't accustomed to proactively managing prolonged NBM status and high-output NG tubes. It's just not their bread and butter.
Exactly. The guidelines also mandate early dietitian involvement for any patient who is likely to remain NBM for more than 5 days. We need to have a much lower threshold for initiating parenteral nutrition.
Yeah, if you have a patient with a prolonged, refractory SBO, high NG output, and realistically no prospect of enteral feeding in the immediate future, PN needs to be started to support their immune function and tissue healing.
Now, before we bring this all together, we have to pivot and discuss a completely different clinical beast: malignant obstructions. While we focused heavily on adhesive SBO, the UK colorectal guidance from ACP-GBI, SIGN, and niche section outlines a drastically different pathway when the obstruction is driven by malignancy.
Whether you are dealing with a primary large bowel obstruction with an incompetent ileocecal valve backing up into the small bowel, or a primary malignant SBO caused by diffuse peritoneal metastases, this is an absolute red flag presentation. The entire clinical mindset has to shift.
It is no longer a straightforward plumbing problem. It is a highly complex oncological emergency.
Right. It requires rapid, often emergency, cancer MDT planning. The tension in those MDT meetings is palpable. You are constantly balancing the immediate operative risk against the patient's overall prognosis and, most importantly, their quality of life.
The team has to weigh whether a frail patient with advanced disease would benefit more from an endoscopic stenting procedure as a bridge to surgery, a palliative surgical bypass, or avoiding surgery entirely in favor of medical palliation with aggressive analgesia and anti-secretory agents.
Deciding not to operate on a malignant obstruction, knowing the outcome, is one of the heaviest decisions an MDT can make. But sometimes it is the most compassionate and medically appropriate path.
So what does this all mean? Let's synthesize this down into the gold standard UK pathway that you can utilize on your next acute shift. Based on the aggregate of these major guidelines, the ideal SDO pathway looks like this.
Let's hear it.
First, secure an immediate admission under a surgical team with aggressive, protocolized fluid resuscitation to head off that 25% AKI risk alongside a consultant review within 14 hours. Second, dish the plain films and get a rapid CT of the abdomen and pelvis with IV contrast to map the obstruction and rule out ischemia.
Third, for uncomplicated adhesive SBO, commit to a structured 48, 72-hour trial of non-operative management. This must incorporate strict NBM status, continuous NG decompression, and an early water-soluble contrast challenge like gastrographin to utilize its osmotic therapeutic effect.
Fourth, adhere strictly to your surgical triggers. If the patient develops clinical peritonitis, CT evidence of ischemia, or a strangulated hernia, you abandon conservative management and move to theater within the 6-hour window. Do not fall into the trap of observing a patient indefinitely. Pushing past 3 to 5 days only increases surgical morbidity.
Finally, when in theater, make a highly selected choice between laparoscopy and an open approach. Utilize adhesion barriers for younger patients, and enforce systematic nutritional tracking using must scores and early dietetic involvement on a dedicated surgical ward.
That is the definitive evidence-based pathway designed to reduce hospital stays, lower complication rates, and improve survival. But to wrap up, we want to leave you with a thought regarding where this field is heading next.
We spend so much time debating the subtle CT signs of ischemia or a closed loop staring at mural enhancement at 3 in the morning. With the rapid evolution of artificial intelligence in radiology, models are now achieving near 99% accuracy in detecting closed-loop obstructions and early ischemic changes.
It's amazing.
It raises an incredible question. Considering that NCEPOD found many delays to urgent SBO surgery are driven by theater and anesthetic availability, how much of the mortality in these high-risk groups is actually a failure of clinical decision-making versus a failure of hospital logistics?
That's the real issue.
Exactly. And looking forward, how long will it be until the agonizing decision to abandon conservative management and take a patient to theater is triggered not by the clinical gestalt of the surgical registrar on call, but autonomously by a radiology algorithm? It raises the question of whether our biggest surgical challenge isn't the bowel itself, but the system built around it.
A fascinating shift in how we might practice in the very near future. The technology is catching up to the guidelines, but the logistics still have a long way to go.
They really do.
Well, to all the surgeons, registrars, and doctors tuning in today, if you like this content, then do not forget to share with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages for more deep dives. Thanks for joining us, and we will catch you on the next one.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.